Hi, and welcome to another Medical Director Minute. My name is Dr. Brian Everett, and today I'm joined by Dr. Dave Miramontes, our CMO and a leader of the Resuscitation Centers here in San Antonio. I want to have him on today to discuss what a resuscitation center is and why we need to be taking our patients to resuscitation centers when appropriate. So, Dr. Miramontes, thank you for joining us today. So my first question is, what is a resuscitation center?
So I'm going to back up one step to where we were before we had resuscitation centers. And that was we were doing all this work with cardiac arrest patients. We're taken to a hospital. They're going, yeah, they're dead. Thanks and have a nice day. And they weren't doing aggressive care on the patient. Even if we got ROSC, they weren't doing the hypothermia, the targeted temperature management or induced hypothermia. And then they were disconnecting the vent before the patients had enough time to recover. So what we did is we went back and we looked at the Take Heart America. You can go takeheartamerica.com. And we looked at a consensus statement for what people all over the world, Europe, Australia, our folks up in Milwaukee were doing to improve cardiac arrest survival. And we took those best practices and we made the Take Heart America bundle of care. And what we did here is I wanted to bring that here. This was started by my predecessor, Craig Manifold, and I just took it to the next step. And so what we did is we met with our hospitals and we tried to figure out what would a resuscitation center concept or a system of care concept look like in this track region. And that's where we started. Unfortunately, COVID happened, got delayed, right? And so then we started down the path. So what is a resuscitation center? A resuscitation center is a hospital with an organized system of care. That is a system of care very similar to the system of care for a level 3 trauma center. It has to have a resuscitation center medical director, usually an intensivist or cardiologist. It has to have an ER director. It has to have intensive care, nurse program managers, the registrar to keep track of the data. It has to have a rehab team leader, a spiritual team leader, so ethics, pharmacy. It has to have all the parts and pieces that's going to take care of the patient, not only in the emergency room, not only in the cath lab, but upstairs in the intensive care unit, all the way through discharge and off to rehab. So it's really, really important to have that system of care all the way from entry to exit. And where we're looking at quality and we're looking at consistency, we're making sure they have protocols and that they follow those protocols for our patients. So a resuscitation center involves that whole spectrum of care, and more importantly, that they're looking at that care and making sure they're making improvements. And when they falter, that they fix those problems so it doesn't happen on the next patient. So it's an organized system of care within the hospital that provides ultimate care for the patient. That means very aggressive management. That means taking patients to the cath lab. That may be putting in a left ventricular assist device like an Impella. That may be balloon pumping. That may be aggressive neurological care post-resuscitation with a neurology team that is willing to look at transcranial Dopplers, EEGs, manage their sodium, manage their mannitol, manage their sedation. It's an intensivist team that's taking care of all the little details to include sedation, cooling, prevention of contractures, prevention of bed sores, stress ulcer prophylaxis, all the things to prevent bad outcomes when you're immobilized in the hospital for 48 hours when you're getting cooled. That's the breadth of really what a resuscitation center is all about.
So these patients that we resuscitate are incredibly complex and need a multidisciplinary team in order to improve their overall outcome during their long intensive stay in the emergency department. It takes a multidisciplinary team, not only starting in the emergency department, but throughout their long course stay. And this is going to improve patients' survival and functional status after they get discharged. And that's really what we're trying to create, correct?
Right. So these are really complicated patients. So they make a stop in the ER, and we know that they should be in the ER not longer than 20 minutes before they go to the cath lab, for example. Then the cardiologists, the plumbers, can fix all that stuff that's going on if they have a reason, whether their arrest was caused by ischemic symptoms or a clogged artery. Surprisingly, a lot of times they have clean coronaries, and this was a primary arrhythmic death, or they have a structural heart abnormality that caused them to go to VFib, VTAC. So then there's the intensive care. That's the management of all the things from hydration to nutrition to vent management to cooling, sedation, anticoagulation, nutrition, and then physical therapy that starts on admission, preventing contractures. It doesn't make any sense to spend all this time and energy to resuscitate a patient and then save their lives and get them ready to go to rehab if they have foot drop or wrist contracture that prevents them from functioning on discharge. So that's what that whole breadth of the thing is. So with the resuscitation center, we often can fix the plumbing. We can fix the clogged arteries. We can sustain a patient with all these different modalities until their stunned myocardium gets well and we get them out of cardiogenic shock. We can fix their kidneys. Usually they come back. We can do chronic renal replacement or dialysis while on ECMO even to keep their kidneys going. The liver usually comes back. The issue is the brain. And that is the part where patients die from their ischemic encephalopathy, or they swell up. Their brain dies and swells up. And we can't do anything for that. So what we have to do is everything we can do up front to prevent that from happening. So that's elevating the head. That's cooling for 24 to 48 hours, slowly letting them rewarm. Managing their sodium, giving mannitol, seizure prophylaxis, monitoring their blood flow. All of those things are part of the equation, the secret mix of getting a cardiac arrest patient or a patient in cardiogenic shock through recovery.
Are there different types of resuscitation centers? Like we have different levels of trauma centers. Are there different levels of resuscitation centers?
There certainly is. So we have our primary resuscitation center, which is, for example, Downtown Baptist or Christus New Braunfels, right? And so they're acting at a level 3 trauma center correlation with all the pieces in place. The only thing they don't have is some of the advanced heart failure therapies, that being ECMO, that being the LVADs, some of the surgical things that are required for really, really sick patients. They can take care of a patient with a ischemic cause. Let's say they got a clogged LAD, they arrested, they came back. We take them to the cath lab. They open up the vessel, put stents in, and then they can manage their recovery if they don't have severe cardiogenic shock. So that's the primary resuscitation center. The comprehensive resuscitation center, right now, the only one we have is University and Maine Methodist. And they have more tools in the toolbox. So they do have Impella at the primaries, but they have Impella, they have LVADs, they have ECMO. ECMO is basically putting a patient on bypass, where you actually cannulate an artery and a vein. You take the blood out of the vein and you pump it backwards through the artery, and you're maintaining a patient. Their heart is minimally functioning. And so we can manage their oxygen, their carbon dioxide, their blood pressure, perfuse their brain while we're waiting for that heart to recover from their rest. And like Maine Methodist does heart transplants, they can keep a patient on ECMO for weeks to months while waiting for a heart transplant. And those therapies are available at Maine Methodist. Now, University Hospital is also a comprehensive resuscitation hospital. They do have ECMO. They have the advanced cardiology capabilities. They just don't do heart transplants.
Yeah, it seems like we have a great system being developed, and I'm sure we'll have other systems coming online in the future. What patients would you preferably go into these centers? We want to take certain trauma patients to certain level centers. Does that change or based off what the capabilities these systems have?
They sure do. So, for example, at San Antonio Fire, we have the shock call go. So if you have any kind of VFib VTAC where you're requiring a shock, either by a bystander, by an engine company, or a medic, they're supposed to call the medical director after you get information and get that patient packaged to go. And we're going to take that patient specifically to Maine Methodist. Maine Methodist, when working with San Antonio Fire on a pilot program to do ECMO CPR. In other words, the patient isn't resuscitated yet. They're still in VFib. They're still in VTAC. They're on the Lucas. Hopefully they've been intubated or they have a supraglottic airway in, and they put them on bypass
in the ER. So we roll in with a patient getting CPR in BFib TAC. They cannulate their left femoral artery and their femoral vein. They put them on bypass. They run an I-stat to check their electrolytes and their blood gas. And then we put them on pump. And then after they're on pump, we don't need CPR anymore. They're on bypass. So now we have time. Now we can go upstairs to the cath lab, figure out what's going on. Do they have an ischemic cause? We'll fix it. Do they have a heart failure cause? We may put a left ventricular vent in or a Impella device. And then we can then take them to the ICU after that and stabilize them in the ICU until we figure out what's the therapies that person needs for their specific cause of their arrest. Okay. So that's the kind of thing that we're doing with a comprehensive center. Now, if you're on the south side, for example, and you have a cardiac arrest that you've resuscitated, you have ROSC, they need to go to Downtown Baptist, one of our primary resuscitation centers, so they can go to the cath lab, get their vessel fixed, and hopefully get going. If you have someone in cardiogenic shock, that might be a great place to take to either the closest primary or to one of the comprehensives so that they can get that advanced level care of ECMO while we figure out why they're in a horrible cardiogenic shock. So those are some reasons why to think to take a patient to a resuscitation center. In the San Antonio fire system, if you're transporting a cardiac arrest patient, they must go to a resuscitation center, either a primary or comprehensive, based on what they're doing. We only take ECMO, CPR, shock Gulco patients to Maine Methodist currently.
So there are options for our resuscitated patients, and work with your medical director to determine what's the best place for your patients in your system, and making sure that we are trying to improve the outcome, long-term outcome of these resuscitated patients that we've worked so hard to resuscitate pre-hospital. Is there some signs or symptoms that would suggest the patient's in cardiogenic shock after we've resuscitated or while we're doing our initial evaluation?
So you may have one of two flavors of ROSC. You get the ROSC where you've given a dose of epi, you get pulses back, their blood pressure's 220 over 110. They've got bounding pulses. You can see their carotid beating. That person's not in cardiogenic shock. They had an arrhythmic death and they've got preserved ejection fraction. So that one could probably go to either a primary or comprehensive, whichever's closest. They need to go to the cath lab. Okay. Now, on the other hand, you've got somebody with decompensated cardiogenic shock. You get them back, their blood pressure is 70. They barely have a carotid pulse. Their capnography is marginal. It doesn't go up to 90 after you resuscitate them. They're hovering in the 30s. You're having to use pressors. That's a person that probably needs a little more cardiovascular support, and a comprehensive might be a better option for them, just like in a trauma. Let's say you're way down south at the Walmart by Mission Trail Baptist and they get stabbed. We're not going to the hospital next door. We're not going to the freestanding next door at City Base. We're going to BAMC because there you're going to drive up 37 and around. And we're going to BAMC because that patient needs the specialized surgical specialty of a level 1 trauma center. And rightly so, that patient with cardiogenic shock probably ought to go to a comprehensive or at least a primary resuscitation center so they can get optimal care for that condition. So we think about patients in cardiogenic shock. They have heart disease. They suddenly in cardiogenic shock with a low blood pressure. Those are folks that we're going to maybe shunt to one of the resuscitation centers instead of going to a local place with a PCI.
Yeah, so it's triaging in the pre-hospital field, getting to that definitive care, what we already do really well. And we can continue to do well for these patients. So we definitely have a system of care improving here. We want to see better outcomes. We have a quality improvement process related to this resuscitation center. And we also have a committee, the resuscitation committee that I mentioned at the beginning, part of STRAC. Can you just tell us a little bit about what that committee actually does and how it's going to be improving the care for our patients over the next couple of years?
Yeah, so we have a couple different service lines within the resuscitation center concept. So we started with cardiac arrest. That's what we just talked about. We're moving into the care of the patient in cardiogenic shock, which is some of what I talked to as well. And we're going to have regional guidelines so that if there's a patient in a regional ER, we're going to quickly identify and move them to a comprehensive care model. We have a group working on sepsis,
Of course, we've talked about that before, which is part of the resuscitation. That's a different kind of shock, right? That's a distributive shock and a hypovolemic shock from sepsis. And then we have another group that's working on PE, on pulmonary embolus. They often present in a cardiogenic shock looking picture, and they need specialized care. Also, all of the four systems have some kind of, that's Christus Baptist, Methodist University, have some type of a PE or pulmonary embolism response team method. And oftentimes, the really sick PE patients that have signs and symptoms of shock, they need to go to a comprehensive resuscitation center so they can get ECMO. We're going to fix their PE, but they're going to need ECMO until we can. So those are the big areas that the resuscitation committee is working on right now. Again, trying to provide a system of care, provide a triage method, especially for patients coming from the other 22 counties besides Bexar County, and how to get them to definitive care.
Well, it's great to hear that we have a process to improve the outcome for these patients. We starts with EMS, but it really is the system of care across the board, both us doing good quality neuroprotective CPR, resuscitation, identification and triage of these patients, moving them to the appropriate center, and then the system of care continuing that hard work that we've done to see these patients have great outcomes, able to return back to their normal activities, their normal life, and be with their families as a result of this process. So thank you for all your hard work, and we look forward to seeing the improvements of our resuscitation scores across the board. Is there anything else you want to add before we sign off?
The single most important thing that determines outcome is something very basic. That is getting hands on the chest. That's bystander CPR, telephone assisted or dispatcher CPR, and high quality CPR by EMS. That is the most important. It's not the stuff in the paramedic drug box. It's not the fancy machines at the hospital. The most important determinant of survival is high quality CPR and to get it done quickly. High quality or neuroprotective CPR includes using a device, either the rescue pod and the rescue pump, or the rescue pod with the Lucas, and then maybe heads up CPR, which is something we're working on in our region. The single most important determinant of survival is high quality CPR. And then all the other stuff are adds on to that. So it starts at the home.
Your EMS agency should definitely be working on finding ways to reduce that time from arrest to hands on the chest by working with your community, hands-only CPR training, getting your police, fire, EMS, everybody on the same role, doing that CPR, getting that AED to the patient, and trying to resuscitate these patients early, limited, no-flow states. So thank you again for your time. We look forward to seeing you. If you guys have any questions, please put them in the comments, and we'll definitely answer them as we can. If you enjoyed this video, please like, subscribe, and we'll see you at the next one. Thank you.